Hello, everyone, and welcome to today's webinar, Engaging Communities in Faith-Based Models of Care. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. When you join today's webinar, you selected to join either with your phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You do have the opportunity to submit text questions to our presenters today by typing your questions into the questions pane of the control panel. You may send in your questions in at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Lindsay Goldman, CEO of Grantmakers in Aging, and our moderator for today's webinar. Lindsay?
Welcome, and thank you so much for joining us today. I'm Lindsay Goldman, the new CEO of Grantmakers in Aging. Grantmakers in Aging is a national membership organization of philanthropies that acts as a relevant and responsive network, resource, and champion, amplifying the voices of older people and the issues of aging. Our vision is a just and inclusive world where older people are fully valued, recognized, and engaged in ways that matter. We want to thank the Coalition to Transform Advanced Care, CTAC, for presenting with us today. CTAC is dedicated to the goal that all Americans with serious illness, especially the sickest and most vulnerable, receive comprehensive, high-quality, person and family-centered care that is consistent with their goals and values and honors their dignity. They achieve this by empowering consumers, changing the healthcare delivery system, improving public and private policies, and enhancing provider capacity. We'd also like to thank the John A. Hartford Foundation for their support of today's webinar. Today, we're going to talk about the role of faith leaders in the healthcare delivery system. Because we have inadequately addressed the healthcare and social needs of large segments of our population, including many African Americans, people living in rural areas, and people living in poverty, these groups are consistently overrepresented in the prevalence and mortality data associated with long-term illness, as well as COVID-19. Too often, well-intentioned clinicians, researchers, and even consumer advocates parachute into a community to help address health disparities without first gaining the trust of the community. I want to acknowledge that this has been an emotionally charged week, and given that we are mourning the tragic loss of Micaiah Bryant and so many others, earning trust is particularly crucial and difficult right now. Over the next hour, our expert panel will speak about how they are working with African American faith leaders to build the trust required to increase access to care, to improve the quality of care delivered, and to enhance the quality of life for people struggling with advanced illnesses. Joining us today, we have Loren Pogir, founder and managing director of Transforming Care Partners and consultant to the Stupski Foundation. Amber Slichta, Vice President of Programs at the Ralph C. Wilson Jr. Foundation, and Elder Angela Overton, Senior Advisor to the Interfaith and Diversity Work Group of the Coalition to Transform Advanced Care. Thank you so much for being with us. As mentioned earlier, you can enter your questions for our panelists at any time in the question box on the right-hand side of your screen. I will collect these questions and read them during the Q&A portion after the presentations. And now I'd like to turn it over to Loren Pogir. Thank you.
Hi, Lindsay. Thank you so much. So I am delighted to be here on behalf of the Stupski Foundation to really share with you the incredible work the Alameda County Care Alliance has been doing to really scale what they call a faith-based, actually they call it a faith-founded model of care to improve quality of life for people with serious illness. Next slide, please. So I think we all know that there is an urgent unmet need. Compared to white Americans, Black Americans are much more likely to experience advanced illness, later detection of illness, medical mistrust, and significant unmet needs around physical, spiritual, social, or even practical. At the same time, we also know that Black Americans are less likely to receive the kind of quality of care that reduces unnecessary suffering and improves quality of life. And this has been happening for a long time, but the pandemic has amplified these disparities. Next slide, please. So the Alameda County Care Alliance was co-founded by Reverend Cynthia Carter Pereliot and 4 other pastors from local churches in Oakland, California. And Cynthia has personal experience with her father's death and later working in hospice. So she really understood this and understands this urgent unmet need. The other thing Cynthia realized is that it's not just one individual or one organization that can fill that need. And so one of the first things she did when she started at Allen Temple Church is she brought together leaders from faith communities, from health systems, and from community-based organizations. If you can go to the next slide, please. So she brought these groups together to really talk together and develop a strategy of how they could work together to fill these needs. And this is really the impetus of the creation of the program, which if you can go to the next slide, they refer to as the Advanced Illness Care Program. And this is a program that's really been developed over a number of years. And what it is it's a Care Navigator-led community-based program. And the Care Navigators work directly with persons needing care as well as family caregivers. And it tends to go over about a 6-month period. There's 5 to 12 visits, and they touch upon these 5 pillars. I just want to spend a little bit of time talking about these 5 pillars. The first one is spiritual, which is incredibly important. They offer prayer, meditation, support groups, and recommendations for church ministry. And as an example, what we see is that of these visits, 85% of those visits contain prayer. A second pillar that's critical is social supports. And over the period of the program, what we see is there's an average of about 3.5 referrals into social supports. Could be transportation, meals, housing, or applications for financial assistance. The third pillar is really critical, and that's about health. And one of the important things they do is they really empower their participants to be ready to actually go into the health system and to advocate for themselves, for their needs, and communicate effectively with physicians. And there's actually a tool that they use, which actually one of it's actually it's a more formal name, but Mary, who's the supervisor, likes to call it their 15 minutes of fame tool, which I think says so much. It reminds everybody that you have about 15 minutes and how to use that most effectively. So in addition to empowerment, they also provide referrals. They advocate for people getting the care they need, and they provide referrals into things like specialty palliative care if it's needed. The last thing is advanced care planning. So they spend a lot of time just making sure people are aware and understand the importance of advanced care planning. And what we found in the program is about 55% of the time, people have completed advanced directive, and that's compared to 15% national average. And the last one I'm going to spend some time on is caregiver support. And this is really critical. So they provide support not just to the person needing care, but also to the caregiver. And one thing they found is that sometimes actually the recipient of the program is the caregiver because their needs can be even greater than the person needing care. The other thing they've seen over time is that there's dually eligible people for the program. So people who are people needing care and they also are family caregivers. And the last thing that the program sees is that sometimes somebody will come in as a family caregiver and later they'll enter the program as a person needing care. So, a couple more things I want to say about this. One is that across every single visit, they talk about goals of care. And what that enables the program to do is really tailor this to what the greatest needs are from the participants, and also recognizing that participants are at different places in their journey of what they would accept. And the last thing I want to point out is that, as you can see from this program, you really need a partnership with your faith community, with the health systems, and with community-based organizations to make this work. And so if you can go to the next slide, please. If you fast forward from when they first started to where they are today, they're now a community of 42 churches. They're partnering with health systems, so Kaiser Permanente, Alameda County Care Alliance, Alameda County Health System, which is our local safety net, and Lifelong Clinic, and about 20 community-based organizations. If you're going to go to the next slide, I just want to highlight the really critical role that that all of these players have in delivering this program. The first one is the Care Navigators, who are trusted community members. And pictured here is Alexa Owen. She is somebody I've had the real privilege of spending time with, and she's exactly the kind of person that I know I would want by my side if I had a serious illness. If you go to the next slide, please, faith community and trusted faith leaders play an incredibly important role. So this is Reverend Ron Reams. He's the pastor of Center of Hope Community Church. And Reverend Reams, along with multiple other faith leaders, offer prayer, whether that's in the home or the hospital. They make referrals into the program. They accept referrals from the program. And in addition to also helping at the individual level, they contribute at the community level too. So they work together to develop sermons around advanced care planning. And they've also participated in pastor-physician dinners where they work together to really talk about how they can work together to support people with serious illness. And if you go to the next slide, I want to mention that health systems, and in particular, health system champions, play a really important role. And pictured here is Melissa Stern. She's the managing director of supportive care services at Kaiser Permanente. And she's actually the first person who told me and the Stupski Foundation about the Alameda County Care Alliance. And in addition to being a really important advocating for other funders, she's in the process right now of integrating the Alameda County Care Alliance into Kaiser, where the Kaiser will be making referrals into the program and also reimbursing them for the services they're providing. If you can go to the next slide, thank you. So, so physicians and additional operational leaders having a really important role. That pictured here is Kevin Nguyen, who's a palliative care physician at Kaiser. If you go to the next slide, please. A couple other people I want to mention is Dr. Jessica Zitter and the late Dr. Richard Payne. So these are physician leaders who have been partnering with Alameda County Care Alliance over time. So in addition to advocating from their systems, they also come together to provide trainings. So they will provide trainings for faith leaders. And I had the real privilege of sitting through a one-day training where I experienced this. And it also goes both ways, where what we see is that they also accept training or advocate for training from faith leaders to clinicians. And next slide, thank you. So their outcomes are incredibly impressive. They have been partnering with the UC Davis School of Nursing really for the past 5 years. And what that's enabled them to do is evaluate the program and also even refine their evaluation methodology. And just one number I want to touch on really quick is the fact that since they started collecting data in 2016, they've directly touched 1,400 people in the program, and so directly served 1,400 people and touched about 15,000 people, which is incredibly impressive. But more impressive, I think, than the quantitative outcomes is really what people say. I just want to share a couple of quotes. If you go to the next slide, this is a quote from somebody needing care who said, "Now we can go in there and already have a plan. We don't have to wait for the doctor to tell us the plan. You don't have to just listen to what the doctor says, you have a say." And another quote on the next slide, which is from a caregiver who said, prior to my mother's death, she, the care navigator, provided comfort. She gave me phone calls, she followed up, she plugged me with resources. She prepared me emotionally by describing me the process that my mother may have to go through and the decision I might have to make. If you go to the next slide, I'm just going to touch upon this briefly about their path to scale and sustainability. So just a couple of milestones I want to mention. The one is where they are right now, which is piloting the program with risk-bearing payers who have the financial and regulatory incentives to continue to sustain the program. And with the support of Kaiser and the Stupski Foundation and others, we're currently just launching those pilots. And another important milestone is the one prior to this, which is getting them ready to even be able to do that. So the Stupski Foundation, again, Kaiser, multiple other foundations have been really supporting them to refine their intervention and enhance their infrastructure. And an example of this is they've just launched a technology tool that's really enabled in them to really even create more efficiency in the program. And if you go to the next slide, I just want to highlight that this has really been a journey of a lot of people supporting the Alameda County Care Alliance over time. And I in particular just want to call out my foundation colleagues. So Rachel Wattman from the Reed and Alex Hillman Foundation was one of the first people after Kaiser to tell me about the Alameda County Care Alliance and actually invited me to a site visit, is how I was first introduced. And been partnering over time with the Callison Foundation, the Harmon Foundation, as well as the California Healthcare Foundation. So we all get together on a regular basis and talk about the program and what we can all do to help support it. So, you know, I just want to highlight that philanthropy is also an incredibly important, has an important role in this. And last slide is what you can do. So I would love to start, you know, please make connections in your community. And I think you're going to hear a lot more about from the other speakers about the importance of doing this and how to do that. I would also say that if you have an existing program like the ACCA in your region, please support it. I really do believe this is the future of healthcare. And the last thing is that if you don't already have a program similar to this in your region, please consider helping the ACCA scale their impact. They're looking for additional payer partners. They will need operational infrastructure in advance of scale. They're constantly developing tools for physician and community engagement. There's one they're working on right now with Dr. Jessica Zitter. I also just want to mention there's quite a few regions right now that have been reaching out to them that are looking for support. So that's LA, Detroit, Baltimore, DC, and Massachusetts. So if you're a local funder in any of those regions, please just keep in mind that those regions have been reaching out looking for support. And just want to thank you for inviting me to speak on behalf of the Alameda County Care Alliance, and happy to take questions even after this webinar. Thank you so much.
All right, well, good afternoon, everyone. As Lindsay said, I'm Amber Slichta with the Ralph C. Wilson Jr. Foundation. And I just want to thank Lindsay and Grantmakers in Aging, as well as John Broyles and his team at CTAC for inviting me today to talk about a project that we've been working on locally in Detroit and Buffalo that really got its start with CTAC. But before I do that, I just want to take a minute for those of you who are not familiar with the Ralph Wilson Foundation. We serve Southeast Michigan and Western New York. We have four programmatic focus areas. You can see them on the screen. And really what got us involved with Grantmakers in Aging and CTAC is our emphasis on caregivers. So next slide, please. So why do we focus on caregivers? You saw a picture of Mr. Wilson on the other screen, and he did something very unique. Before he passed away, he had decided that, all of his companies would be sold and the funding would go into a foundation. And his only requirement was that the funding all had to be spent within 20 years. So he appointed 4 lifetime trustees, and they were in charge of selecting the programmatic focus areas that the foundation would invest in. And they all knew that Mr. Wilson had a passion for caregivers, in particular at the end of his life. And in fact, he had written a letter suggesting to the lifetime trustees that they might want to focus on caregivers. So as the lifetime trustees were sorting through what we would focus our investments on, they really honed in on the fact that we have an aging population. There are very few funders that focus on aging, let alone caregivers. And by and large, caregivers, both paid and unpaid, are really unsung heroes. Not much attention gets paid to them necessarily, and they often do their work very quietly, but it's incredibly important work. So we saw a huge potential for impact by focusing on caregivers, and specifically caregivers of older adults. So I won't read the quote to you because I'm sure many of you have seen it before, but I do think Mrs. Carter summed it up very well when she said there are only 4 kinds of people in the world: those who have been caregivers, those who are, those who will be, and those who will need them. So next slide, please. So with all of this in mind, we began our caregiver work, and we were thinking on and off about how can we engage the faith community in caregiver work. And it really seemed like a no-brainer to us that we ought to be involving faith leaders. They talk one-on-one with caregivers every day. They have intimate, close relationships with their congregations that often the healthcare system really doesn't have the opportunity to have. We knew very much that faith communities oftentimes have a bit of a different approach to thinking about end of life, how they engage families and caregivers in that process that's very different than the healthcare system, and that both, really have an awful lot to offer each other as they think about these things. So, you know, a little bit differently, I think, than Loren described, we took a little bit more of a shotgun organic approach to this and said, well, the CTAC conference in 2019, we've been there a couple of times. They do a terrific job. They have a faith leader track. So let's take some faith leaders with us to the conference and see what happens. So I'm not sure if you can see the pictures really well here. These are from my phone, and I'm not really a photographer, but we took over 20 faith leaders from Buffalo and Detroit with us, and really just, you know, let them do what they needed to do at the conference. If you haven't worked with faith leaders before, they are not afraid to share a meal and a cocktail, so we did that as well, and just had an amazing time. And then when we came back, so next slide, please. Over the last 18 months, we've continued to engage a facilitator in both Buffalo and Detroit. So the original faith leaders that attended that conference have continued to talk. Some have moved on to other things. Others have stepped in, and we were really getting things going about a little over a year ago when COVID hit. And ironically, we had held a summit in Buffalo, New York with over 40 faith leaders to really move the work forward, on March 12th, and then things shut down. So what came out of that summit were a lot of suggestions, things that we ought to be paying attention to. There was really this overarching theme of the importance of paying attention to the social determinants of health. And as I said before, this has really been a very organic process. And, you know, I think both Lindsay and Loren mentioned trust. So our foundation has really stayed in the background and just let the faith leaders continue to meet, continue to learn more about what's important to them, work with the facilitator, and take the time that they need to take to get to a place where they're ready for some grant funding to move forward in engaging with caregivers more. And that's really been our only requirement, that this is about family caregivers of older adults. So whatever they would like to do, we're, you know, more than willing to support. But we really want it to come from the communities and not from the foundation or be anything prescribed. So both communities at this point are at a place where in Buffalo, they feel as though they've been educated enough about caregivers that they're ready to make some decisions about where they'd like to go. And I think in the spirit of trust that they've built with us as a funder and some other local funders, they said, well, now we need to hear from our congregations about what is really important to our members, not just us as the faith leaders. So they're going to be using something called the Caregiver Intensity Index that some of you may have heard, that was developed by an organization called Archangels. And it's a tool that's designed for caregivers to hop on and do on a regular basis. It asks a series of 20 to 40 questions, depending on which version you're doing, but it gives them a snapshot in time of how am I doing right now and what's going well, where, you know, do I deserve a pat on the back, where might I need some resources, and then gets them connected up to resources. But it will give the faith leaders some data about where their congregants are in their caregiver journey, and they really want that data to help them decide where to start, so in turn they're meeting the needs of their congregations. In Detroit, they've had quite a few meetings over the past year, and they're getting ready to submit a request for funding to develop something called a congregational caregiver. And this individual will start by working with 4 or 5 different congregations, and they will really be there to work with the faith ministries that already exist to really be able to emphasize caregivers and how to support those family caregivers within their congregations. So again, this has been a very organic process, and it's taken the time that it needed to take, and I think we're in a very good place. A couple of really good unintended consequences that have come out of this process. During COVID, we were staying in touch with the facilitators, and the faith leaders, and had a couple of unique opportunities that actually bubbled up in part from the faith leaders. In Southeast Michigan, we received a request from the Director of Aging for the state to provide something called Q boxes. They were boxes of food that was non-perishable that would last for about 10 days. And what the Director of Aging wanted to do is she wanted to get 10,000 of these out in Southeast Michigan. So we said, sure, we'd be happy to help with that. But what we were both concerned about was we really wanted these to get to the folks that were really hard to get to, you know, not the ones that could drive to a AAA or a Meals on Wheels or, you know, a specific location, or already had something like Meals on Wheels in place where they could drive to people that they already knew. And it turned out the key to getting these Q boxes to folks that were not already signed up for a meal program, maybe wanted to be, and allowed a lot of organizations to find more people in need, was through the faith leader relationships, in part, that our foundation had developed in partnership with the AAAs. So that was incredibly important and probably would not have happened were it not for the faith leader work that started at the CTAC conference. The second thing that happened is in Buffalo, New York, there's a minority newspaper called The Challenger, and they were starting to have financial challenges like many news outlets were during COVID. And on behalf of this minority newspaper, the faith leader said, you know, they could really use some help. And we said, okay, well, that's great. You know, let's figure that out. But there are many other minority-owned news outlets. How can we help them as well? So with that one conversation, we ended up funding 7 news outlets across Buffalo and Detroit, and I think we made an investment of about $250,000. So again, you know, some really terrific, you know, unplanned, unintended consequences. So our next step in this work here is really, we're getting prepared at our September board meeting to bring some proposals to our trustees for consideration to really get some projects going in Buffalo and New York. You know, and it's just been a great journey, and we're very much looking forward to returning to a CTAC conference or even a GIA conference, so that the faith leaders can continue the discussion about whether or not the Bills are better or the Detroit Lions, but I am certain it's the Bills, and if you follow football, you know that it is too. So thank you, Lindsay.
Good afternoon. It is so wonderful joining all of you. My name is Elder Angela Overton, and I am just delighted to be among such wonderful individuals. It's great to be with Loren and Amber today. I've had the privilege of working with both projects because of the position of being a senior advisor for the Coalition to Transform Advanced Care. My role is to partner with currently we have over 100 faith leaders throughout the United States that are just committed to engaging and hearing and listening to best practices. Our projects that CTAC is currently working on is really committed to supporting Black, Indigenous, and people of color entrepreneurs, plus disseminating their initiatives. The purpose of this is the why of why we are doing this. And so we're going to focus not on those projects, but specifically the Louisville Pilot Project. Our focus for the Louisville Pilot Project was to engage with faith leaders who I believe are decision support persons. And in any healthy model of care, decision support persons are an encompassing and a necessary component. We engaged faith leaders in the 40203 zip code in Louisville, Kentucky, who provided knowledge, care, love, and support to those in their community. Historically and presently, this is a community that is underserved. CTAC's main objective for this project was to learn how we could improve serious illness care for those afflicted with poverty and systemic racism, and then hearing how faith leaders and persons in this community suggest we as organizations should respond. Project lead Reverend Adrian Baker, that you see here on the right, for one of the places of worship we partnered with, said, good enough is not good enough. The practices, programs, our operational systems that are in place that services persons in community are not efficiently and effectively working for all, only a selected few. Next slide. CTAC has a moonshot goal. 12 million Americans living with serious illness will have high quality of life. To reach this goal, our focus, policy advocacy, and catalyzing community and state coalitions. Catalyzing community is what this faith leader engagement model of care did. We partnered with faith leaders to connect with persons and their caregivers to introduce self-management support organizations, agencies, and entities that could address the needs that the faith leaders surmised were leading factors and impediments to those with serious illness having a good life. Next slide. So why is this way of engaging necessary? I really do hope that you all hear this. If you don't hear anything else, please hear this. Faith leaders are critical connectors of the development and validation of the process to care. Faith leaders can speak the language, whether it be spiritual or practical, in a way that is not only understandable, but receivable, convincing, and speaks to one's convictions. Quality of life, especially most in need, equals investing in faith care-driven coalitions. Access to care equals investing in faith leader-driven coalitions. Changing the care model, investing in faith leader-driven coalitions. Investing in trust equals investing in faith leader-driven coalitions. Next slide. Our objective for this project: connect faith leaders to trusted local resources on serious illness. We did that. Introduce and offer resources that can be utilized now. We did that. And support a model of care that's sustainable and scalable. We're working on that. I'll talk more on that shortly. Next slide. Understanding the serious illness journey in Louisville, Kentucky, 40203. U.S. federal poverty guidelines used to determine financial eligibility for certain federal programs says that poverty levels is $12,880 annually for an individual and $26,500 for a family of four. In this zip code, about 52% are living in poverty. This means that if you make this amount of money or less, you're living in poverty. And so there were so many others that may have been in the $13,000, $15,000, or $30,000. As I saw, that's still living in poverty. United Nations answers the question, what is poverty? This way. Poverty entails more than the lack of income and productive resources to ensure sustainable livelihoods. Its manifestations include hunger and malnutrition, limited access to education and other basic services, social discrimination and exclusion, as well as the lack of participation in decision-making. Studies have shown people who live in poverty are more likely to have fair or poor health, are obese, are food insecure. This means they lack proper nutrition, they are hungry, they are worried about rent and monthly bills, they are more likely to have low trust of people, no usual source of care, delayed getting care, more likely unable to afford prescriptions, difficulty paying medical bills, dissatisfied with care, and less likely to get screening such as cholesterol, mammograms, colonoscopy, etc. The Center for Disease Control notes African Americans are at least 50% more likely to die prematurely from heart disease or a stroke. Next slide. So what did we do in 7 months? We met 2 African American faith leaders in Louisville, Kentucky, 40203, where we listened to their vision for care for those with serious illness, especially during this time of COVID-19. And based on the needs and asset assessment the faith leaders completed, we co-designed and implemented a strategic plan to meet those needs. Faith leaders completed a self-report of this project, and we interviewed 25 individuals from the community where they answered the question, are you in good health? I wish I had time to share with you all that we learned in this Are You in Good Health. Mind you, if you would like to talk further, you have my email address, please reach out to me. Next slide. We provided grief support training for associate ministers and deacons. 93% felt more prepared to provide grief support. We provided advanced care planning in person, masked, and socially distanced. 10 individuals created and had notarized advanced care planning documentation in the last 3 months. We provided caregiver support via a caregivers virtual celebration program where we honored caregivers and had 3 community-based organizations representatives as guests to share support and resources. I tell you, we utilized this same sort of model that Alameda County Care Alliance used. It's this way of supporting caregivers by honoring them first. We addressed local organization determinants of health via connecting faith leaders and surrounding community with 13 local partners through the CTAC network. Reverend Adrian Baker and Pastor Alma Woolley and myself presented and have shared nationally. We also partnered with AARP to plan, market, and execute food and essential drives. Next slide, please. Project lead Pastor Woolley said, the grief supporting training was put to use immediately. Our ministers and deacons feel more comfortable comforting others and having a contact person within the community that we can go for resources and answers is gold. Project lead Reverend Baker, he says, it is great to provide a grief outlet for a family supporting a child with stage 4 cancer. I want to say that that person with the little child, a little boy with stage 4 cancer has since transitioned. He has passed away. And I'd like for you to know that in the last 7 months of his life, we were present, we were there. And this family was dealing with poverty. And so we were able to provide food and essentials and clothing and things to support this little guy. So thanks to New Connections, better prepared to be a resource for community members to access food, housing, transportation, and health resources. This is what we were able to do through dedicated partners in this region. Next slide. This model of care did not create sustainability. That is meeting the basic needs: food, housing, health insurance, transportation, and internet. And so I want to talk to you about more about what we're doing. Will you please go to next slide? As I said, just creating something that is sustainable and scalable requires a community. We are going to continue in our evaluation of this pilot project and how we have impacted. We're working with other organizations there on the ground: AARP, Hospice Health, Norton Healthcare, Louisville Presbyterian Seminary, and the National Center for Complex Medical and Social Needs. The idea that what we learned is that social determinants are a major issue in healthcare and quality of life. It won't be enough to do just enough. We have to together come up with a different plan, a different mode of action. So the next steps for this project is kind of, if you will, turning it back over to the community, and CTAC being the backdrop, if you will, but still present, but allowing major stakeholders, payers, as well as faith leaders and persons receiving care to come together and really tackle what is going on and what do we systemically need prescriptively to do in order to make better. So that's all my time for today. I really am very grateful to be present and know that I am looking forward to further partnerships. Partnerships is what makes the dream a reality. Thank you.
Thank you so much. It's now time for our question and answer period. So please remember to submit your questions through the chat feature. And if we could get all of our panelists to turn their cameras on again so we can ask you all of our questions. Okay, so Elder Angela, are you able to turn your camera on or no? Ah, there you are. Thank you.
I'm sorry.
So what do you think is unique to faith communities when it comes to serious illness care that the healthcare system can learn and benefit from? And related to that, how open has the healthcare system been to learning these lessons?
Well, I have to answer that by saying many times we do not trust individuals who are on the ground doing the work already. I don't know if that's a system or if that is the status quo. I'm not sure. We don't do a very good job, if you will, of partnering with individuals who I believe, are experts, because on a weekly basis, they are engaging with their communities who many times are in need, and all of these projects are sharing the folks that are in need. I don't think that we do a good job. And I think faith leaders sometimes are aware of that. And so that's why it perpetuates a system of distrust and continual distrust.
Yeah, and Lindsay, I would add to that, that in our experience, in particular in Buffalo, where a lot of the faith leaders frame their thinking and their work around the social determinants of health, there's a very much a recognition by the faith leaders that, the health system, on its best day contributes to 20% of your health. And, I think there's this more holistic recognition by faith leaders that, everything matters: where you live, where you can get to a grocery store, how you interact when you engage with the health system. And, if you walk through the health system door, very often, if you don't look like the person who is taking care of you, there's a whole set of assumptions in your head. And sometimes even if you do look like them, that can be a challenge too, because they have assumptions about you. And I think there's a very important role for the faith community and the health system to learn from each other. And to Angela's point, the healthcare system has some really important, incredible, valuable expertise that I think sometimes gets shared in a way that perhaps is not the best way. And I think the faith community can be an incredible bridge to a better healthcare experience, to a more holistic healthcare experience. But there's just not a lot of interaction going on. So I think the work that CTAC is doing is just so incredibly important, and especially at the end of life. And we all know what goes well and what doesn't go so well in the healthcare system there.
And related to that, because your preliminary outcomes are really exciting in terms of increasing completion of advanced directives, but we know that hospice and palliative care are significantly underutilized by people of color. And I'm wondering if you've seen any kind of progress in increasing access to and utilization of those critical services through these programs.
So interesting enough, I'll use an example for this project. When we did the advanced care planning session and we had the individuals complete the documents, one of the individuals, after completing the document and having it notarized, raised her hands into the air, and as if, she was speaking to heaven and saying, I just praise God, because now when they ask me, do you have a living will on file, I can say yes. And so, yes, there is a distrust, if you will, for hospice and palliative care, because, yes, of our history, we have, when an individual says we've done all we have to do, sometimes that language is not really, did you do all that you could do for me? There is years of experiences, not even just the Tuskegee experiment that is in the back of one's mind. It has to do what happened yesterday. It has to do what happened when I approached the administrator's desk. There is individuals that may not necessarily even be racist, but they hold racist tendencies. And so what happens, and they're doing this unaware, very, very good programs, but some of the messaging and language and approach to different cultures, if you're not have culture sensitivities, and so subsequently your approach may be something that cannot be received or is not receptive. So another piece that I always share with individuals, if you are an organization where no individuals look like your target audience, you have a problem in regards to who will utilize your system. Many people, if you have an organization, I know this is kind of very touchy subject, but if you have an organization that is one, if it's, I'll say it as it is, white male, then you're not diverse. And so subsequently there are individuals that won't receive based upon this whole issue of lack of trust. And then also, this is one thing that I have shared with Hospice Health here in Louisville, Kentucky. Also, engaging in this community only at the time of transition does not it does not help. Beginning to engage community early on is very effective in and also in mid-COVID-19, having the opportunity that if this time comes, you will be prepared and aware of all that is available in your community.
Lindsay, I was just going to add. Oh yeah, I was just going to add, this question of like, do we have data to show that the work is increasing access to palliative care? I'll just pick palliative care as an example. So that is actually part of what the Alameda County Care Alliance is trying to do, and that's why you actually need to be able to partner with a health system, is to be able to get that data to show what the impact is when somebody goes into the health system. So just want to say that is part of the data that we're hoping we can get to be able to show that. Having said that, and I do want to say that I think all of us are huge advocates that know about palliative care, are huge advocates of palliative care, and we've certainly seen data to show that once people access palliative care, these disparities do go away. But we do need to meet people where they are, and I think that's something that's really important that Elder Angela and Amber have mentioned as well. That that you've got to recognize where people are in their journey and what they most need and where they are, and so that's certainly an outcome that we want to measure, but it's one of many outcomes that we'd want to measure in terms of improving overall quality of life.
Thank you, Loren. I'm going to stick with you for a minute because sustainability is always a challenge for philanthropy, and for grantees implementing innovative programs. And it sounds like the work that you've described is an example of philanthropy coming together to seed innovation. And it sounds like you have a sustainability plan, because you used the magic word, magic R word, reimbursement. Can you talk a little bit about how that's come about and the potential for scaling with other health systems?
Absolutely. Yeah, and I would say, I would actually say that I wouldn't say philanthropy seeded this. This was absolutely seeded by the Alameda County Care Alliance, bringing together local systems and community-based organizations and faith leaders. I think we've all been in this incredible role of being able to sort of support and grow the seeds. I just want to clarify that. But yeah, so I'm a recovering CPA. I was in financial services for many years before I finally got to do what I've always wanted to do. And so I hate having to think about financial sustainability, but it is so critical. And that is something that we've always have had in the back of our mind of how do we sustain this. I think that that there's a few different ways to do this, right? So I think that there's possibilities to scale within risk-bearing payers. And so Kaiser's a perfect example of that, where they have risk for this patient population. So they have more interest in not just improving top line revenue and bringing people in, but also kind of managing the overall population. So there are, and I will say that this is not about reducing costs, right? This is really about, when we talk to these payers, this is really about improving quality of life, and it's like shifting costs, I think is the way you think about it. So there's a value case to be made with organizations like Kaiser. There's a value case to be made with Medicare Advantage plans. There's a value case to be made with Medi-Cal managed care plans. So I think those really is how we're thinking about the scaling partners. In California, we're really lucky. There's a few regulations that I think are really helping. So SB 1004 is a regulation that's requiring Medicaid plans to offer a palliative care. And so what, in some ways, people would see what Alameda County Care Alliance is doing, and they would call it palliative care, but it's definitely not the medical side of palliative care. So that's why one of the pilots they're working on is in partnership with Alameda Health System and Lifelong Clinic, because if you join them together, then they can actually qualify as a palliative care provider underneath this particular benefit. So that's one example of a way that you can, augment the program to based on what it's intending to do, but in a way that's sustainable. We're also really, trying to partner with our local Medicaid managed care plan. So that's where we see the opportunity. And I think as we think about scaling the program, within Northern California, we're limited to those risk-bearing payers here. But when you think about going to a new region, I think that's something that we could look at is like, where is there a high penetration of Medicare Advantage and Medicaid managed care plans, where there already are champions internally for offering programs like this. So hopefully that gives you kind of a sense of the way we've been thinking about it.
Thank you. That's really helpful to understand. We're coming to the end of our hour, and so I want to give each of you the opportunity to give us one key takeaway. What do you want us to remember if we forget everything else? Because it's hard to retain information these days. I'll start with you, Elder Angela.
Thank you, Lindsay. Listen, when we can build a community where everyone is at the table, taking under consideration who we touch equally, we will improve the quality of life for all. If we can ensure that everyone is at the table, faith leaders play a critical role in this because they touch our targeted audience on a regular basis, probably more than anyone, more than any clinician, more than any clinical provider. Faith leaders are always called. And so if we can move to create a healthy ethos, we could create sustainability. We could create satisfaction. We could create a nation where healthcare is a priority and quality of life really matters. It moves beyond what we say to actionable ways of doing.
Thank you. That's a very inspirational vision that I hope we can work together to actualize. Amber.
Sure. Well, I mean, I've heard so many wonderful things today. I think what, I would encourage everyone to think about after this is, faith communities, have a very unique place in the world and in our country, and there's so much to learn from them. They have very unique relationships with their congregations. And, as philanthropy or grant makers in aging and CTAC, we're in positions where we can connect people that aren't normally connected. And, and I think the important thing there is to make the connections and then step back and see what happens and be there to support what happens and really, not come in with a solution and, try to be the smartest person in the room. Because we're probably not, and the smartest people are in the room are the people who live this every day. And I really believe, our role is to listen and be there to provide the support for the solutions that make sense to the folks with the problems.
Thank you. Loren.
Yeah, I would just say that if you are passionate about improving quality of life for people as they age or have serious illness, please engage with your faith-based organizations. They're really critical.
Well, I want to thank all of you, Loren, Pogir, Amber, Slichta, and Elder Angela Overton for being with us today. I also want to thank the Coalition to Transform Advanced Care for their partnership on today's webinar, and the John A. Hartford Foundation for their support. We will be making today's presentation available to anyone who wishes to view it later, including the slides and the audio. And so watch for an email to be sent within a few days. We have many informative webinars over the next few weeks, starting with Rides That Save Lives on April 27th at 2 p.m. Eastern, which will focus on strategies to vaccinate people in rural communities. And you can learn more at our website, giaging.org. Please follow us on Twitter and our new LinkedIn page, which you'll see on your screen. And please complete the brief survey that will appear on your screen momentarily to help us improve our programming. Finally, I want to thank all of you for coming today and participating in our webinar. Be well.
Thank you.